So today I will talk about laryngeal injection with a particular focus on the transoral approach. So the first laryngeal injection was actually performed by Brunet in 1911. He used paraffin to inject onto awake patients with indirect mirror. But after reporting this injection, technique didn't actually popularize because of the material issue and also the technical difficulties. It was not until 1962 that Arnold started to use Teflon to inject onto patients with vocal cord paralysis. So the injection of Teflon gained popularity because apparently it has a more favorable material profile. And also, at that time, there was much improved in the general anesthesia technique. So more and more injections were performed under general anesthesia for patients with glottic insufficiency, particularly with vocal cord paralysis. But I think most of us here know that Teflon is actually not a really good material for injection and actually can cause granuloma formation. In fact, granuloma formation after Teflon injection can present with a different time frame. So it can range from 4 months to up to 18 years. So that's why Teflon injection, laryngeal injection also lost its popularity subsequently. Together with the availability of other approaches like open phaloplasty described by Professor Hishiki. So more and more open surgery were performed in awake patients for patients with glottic insufficiency. However, the popularity increased again in early 21st century because we have better filler injection materials, calcium hydroxyapatite, hyaluronic acid, and also we have much better endoscopes. So we can have a much better view on the larynx with the endoscope, and so performing more injection again. And in fact, we found that injection is better performed under local anesthesia on awake patient because we can really know how much we should inject instead of injecting on a patient under general anesthesia with paralyzed. So you can see in the United States in the early 21st century, there was an increasing popularity to performing laryngeal injection in office setting rather than in the theater. And apart from injecting for those with glottic insufficiency, laryngeal injection is also performed on patients with other voice disorders, such as hyperfunctional disorders, such as spasmodic dysphonia, vocal tremor. So in 1984, Blitzer and Brin actually started a treatment by injecting Botox to patients with spasmodic dysphonia with good results. And so to date, we perform laryngeal injection for different indications, including different causes of glottic insufficiency and also different hyperfunctional laryngeal disorder, neurological disorders such as spasmodic dysphonia and vocal tremor. And there were also reports suggesting laryngeal injection could help on some voice condition like refractory muscle tension dysphonia, recalcitrant laryngeal granuloma, and chronic refractory cough. So depending on the indication and the need, we inject different materials. To achieve the injection, we can use different approaches. We can perform it percutaneously through the neck. We can pass through the needle through the viral cartilage if it's not really calcified. We can pass it through the thin membrane of the cricofilarial membrane. Or some people would choose to use the viral higher approach, but the drawback of this approach is that there are much more soft tissue that you have to penetrate before you can visualize the needle in the airway lumen. Some people also use the endoscopic transnasal approach to perform an injection, but this may be difficult for some really thick filler, in which the filler may block the thin caliber injection needle. So transoral approach is the other option. As mentioned, you can either perform it under general anesthesia, under direct laryngoscopy, with the patient paralyzed and under anesthesia. Or you can perform it on awake patients in the office or in the day ward setting. So what's the current situation in Hong Kong? In fact, it's also the situation in most Asian countries and cities. Majority of these injections were performed by percutaneous approach or transoral approach, but under general anesthesia, under direct laryngoscopy. Transoral injection on awake patient is not yet a really popular injection technique. So what's the reason behind? So firstly, the transoral approach is a more technically demanding approach. So you have to make sure the patient is well anesthetized without significant gap reflex, and the patient can really cooperate when you, pass through the needle through the oral cavity and the pharynx, which is really sensitive region. And another major reason is that, unlike in Europe and United States, we don't have a commercially available single-use or transoral injection kits. So you can see in these Europe and United States single injection kits, apart from the filler bottle itself, they come with some different needles. Usually they have two types of needles. One for percutaneous injection, a short needle, or they give you a long, malleable transoral injection needle, such that you can bend the needle. And the needle is special in the way that the shaft of the needle is bigger caliber, so it can have a strength to manipulate through the pharynx. But in the needle tip is a very fine needle tip, so that you don't make a big hole after the injection in which the filler may leak out. So in Hong Kong, we have this filler, but it's mainly for the anesthetic dermatological market. We can get hyaluronic acid, we can get calcium hydroxyapatite, but they just come with very short needle, usually performed for facial plastic indication. But does it mean we cannot perform transoral injection? The answer is no. We can actually use some simple instrument to perform transoral injection. So here you can see this is an oral tracheal injector with a single-use needle tip, such that we can use the commercially available filler to inject through the oral cavity to the larynx. So in our center, we have introduced this transoral awake patient injection technique 5 years ago, and now majority of our cases were performed in the clinic setting. So here's a short video to demonstrate how we perform the injection for a patient with vocal cord paralysis. So the first part is actually very important. You have to confirm your pathology. You have to make sure the patient have a cord palsy, have a glottic gap, and then we apply anesthesia. Apart from spraying the nose and the throat, we'll use a drip catheter to precisely anesthetize different area of the larynx and pharynx. So you can see after a gradual anesthetize, the patient have less gap reflex and choking now, even when we are touching the endolarynx, touching the false cord and the true vocal cord. So after the patient is fully anesthetized, we can perform the ejection. You need an assistant to hold the endoscope, and the surgeon will pass through the needle through the oral cavity and manipulate down to the larynx. So you can see it gives you an extremely good view of the whole needle for your injection. So you can see how deep is the needle penetration after you penetrate through the vocal cord. So it allows precise injection and a very good volume titration. So you can see after we perform the injection augmentation, the cord was medialized, and then the glottic gap was decreased. Actually, you can still see some glottic gap because we perform a slight hypercorrection to ensure the effect of the injection. So apart from injection for glottic insufficiency, we can also use the transoral approach to inject Botox to treat hyperfunctional condition. And this is a paper published by Professor Blake Simpson. He used the transoral supraglottic Botox injection technique to treat adductor spasmodic dysphonia. So the benefit of this procedure, in contrast to EMG guide injection, it can allow a smoother onset of action and less breathiness immediately after the injection. But the limitation is that you really have to take longer time to anesthetize the pharynx before you can perform the transoral injection. For laryngeal EMG guide injection, most of the time you don't need to penetrate your needle into the larynx, and you may not irritate the throat too much, so all the time of injection will be shorter. So this is the transoral supraglottic Botox injection. So you titrate the dose of the injection of the Botox according to your need. And all you do is to inject just a little 0.1 ml of Botox solution to each side of the supraglottis at the fourth vocal fold region. And if you want to give a higher dose of Botox, you have to inject more concentrated solution instead of injecting more volume of the solution. So in the last part of my presentation, I just want to share with you, after about more than 100 injections, technical to share with you. Hopefully, if you choose to perform transoral injection, you can master the skills quicker. So firstly, you have to make sure you have a good assistant to hold your endoscope for you. And usually, the operating surgeon need to sit down and have a same level with the patient so that you can see the needle going through the oral cavity and through the pharynx, avoiding the soft palate and uvula. And after the insertion of the needle into the oral pharynx, your assistant will tell you he or she can visualize the needle. Then you can concentrate on the screen to further manipulate the needle. So the second important point is you must adequately anesthetize your patient. Otherwise, the patient will have a lot of choking, gag reflex, and it will make the injection very difficult. So in my practice, I would anesthetize the patient by some nasal spray, cofenicane, which can also decongest the nose for the passage of the endoscope. And in the pharynx, I will spray the pharynx with some xylocaine solution. After that, as shown in the video, I will use the drip catheter under direct visualization. I will drip 2% lidocaine to anesthetize the pharynx and the larynx. Usually, after application of all these anesthetic solution, the patient will have a much reduced sensation and cough reflex. So another little tips is that you should really find some pivot point for you to rest the needle, because if you otherwise the patient tongue movement could actually move your needle and affect your precise injection. So usually I would after inserting the needle, I would rest the needle shaft on the upper incisor and also in the pharynx just over the epiglottis as shown in the picture. So with these 2 points, you can then stabilize your needle, and then you can really do very precise injection. And make sure not to traumatize the oral cavity, tongue base, pharynx when you manipulate your tissue. Otherwise, the view of the endoscope will be significantly affected, and it will again affect the successful rate of the injection. So good endoscopic view, yes, good assistant. And most of the time, if the patient doesn't have much secretion, you may not need a suction catheter to apply the constant suction, which may actually cause some irritation to your patient. And so these are most of the tips. And for the injection, you have to make sure that you don't inject too superficially over the superficial laminar propria level, the rinky space. Otherwise, the patient will have a very bad voice immediately after the injection. Rather, you will inject as illustrated in the diagram, you want to really medialize the TA muscle and also the epithelium, so the body cover theory of the vocal fold vibration will not be affected, so the voice will be much better. Lastly, make sure you manage your patient expectation, because as I've mentioned, when you are injecting for patients with vocal fold paralysis, you inject to achieve slight hypercorrection. So most of the time, the patient may have their voice affected soon after the injection, and it may take days to 1 week to improve. So make sure you talk to your patient, explain to your patient that the voice may worsen shortly after the injection. This is particularly true when the initial glottic gap is a really small one. Unlike those patients with a very big significant glottic gap, after an injection, they will find their voice significantly improve. Their maximum phonation time will improve, so they will be very happy. For those patients, you have a really mild glottic insufficiency. They have only a small gap. Probably the voice was affected also by the secondary muscle tension dysphonia. In this patient, you have to be really careful. You have to really explain to them, you want to correct the gap, but after you correct the gap, correct the physical presence gap, they still need subsequent voice therapy to improve the functional, or I would say muscle tension dysphonia part of the problem, which is not uncommon to coexist for the patient with any glottic insufficiency. So for Botox, you make sure you also explain the possible immediate side effects like breathiness of voice, choking, and dysphagia. Okay. So here comes to the end of my presentation. So I think in the future, we should really popularize laryngeal injection, particularly transoral injection in our region, in Asia, such that we may be able to have advancement. We may be able to attract those companies to really import those single-use kits to this region. I've talked to the company. At this moment, they don't have single-use kit available in Hong Kong, in Asia Pacific area, and they actually don't have really intention to introduce this to this area in the near future. I don't know. Probably there are quite some economics consideration, but if we could popularize the injection technique, we could really possible to get these. And in fact, there are quite a number of patients would be benefit from this approach, because the precise injection could help us to treat some condition like presbylarynx, when the patient really have mild vocal fold atrophy. So all you need is to just a little injection to improve the gap. But percutaneous approach may not be too accurate. But of course, I know we have very experienced hand in the region. Some people can do percutaneous injection really well, really precise, but I'm straightforward. I just see to make the good injection. So that's all for my presentation today. And lastly, I would just want to show my wonderful team to all of you. So, and we have a regular injection clinic every month in our center in PYANH. So if you're interested to see some cases, feel free to contact me anytime. We can arrange. Thank you very much.